we should start.
So, good evening, friends. Respected today's guest, Dr. Narendra Rathi, sir. Our MAHAIP President, Dr. Gangulia, sir. Senior Pediatrician, Dr. Mohite, sir. Chairperson, National Critical Care. Our today's moderator, Dr. Parvez. My secretary, Dr. Dhananjay. State convener, Dr. Jay Bhandarkar, and other key persons also. Dr. Lahoti is also there, pediatric surgeon. So many dignitaries on the board, off the board. Good evening to all. Dear friends, today I have planned this lecture. Actually, it was in my mind long before. I talked with him, Narendra, because I know what is Narendra Rathi. He is one of the gem in that area. And त्याकरता मला त्याला या बोर्डवर आणायचं होतं. Let us have some wisdom from him. So I welcome you all and I introduce Dr. Narendra Rathi. First of all, I introduce him. He is my batchmate, my close friend. Narendra Rathi, he did his MD, DNB and fellow IAP. He has done his clinical fellowship, Institute of Child Health, London in 1988. He is a postgraduate diploma in medical legal system also. Gangulia sir, तुमच्या branch मधले आहे. He is a practicing pediatrician Akola since last 3 decades. He published more than 15 papers in national and international journals. He has served as national editor of served as section editor of the Indian Journal of Pediatrics for 10 years consecutively. He is known for his research work on rickettsial diseases, has devised a diagnostic scoring system. It is well known as Rathi diagnostic scoring systems by his name. And he has received a Best Research Award against that in 2011 by Asian Society of Pediatric Research. He was assistant professor pediatrics at GMC Akola and also is a teacher for DNB and CPS DCS students also. Recently awarded for obtaining highest number of gold medals in 75 years of history in GMC Nagpur. He bagged more than 7 gold medals in MBBS level. So this is in short, the list is English, but we have to start his lecture. I would like to mention here that before starting my practice at some small town in Vidarbha region, I have worked under him for 1 month, and I didn't have any hesitation to work under him, because though he is our friend, but we consider him we see him as our academic guru, as we see to Dr. Mohite sir. So in short, I finish this introduction. I request Dr. Parvez to take over the charge as a moderator. Thank you very much. Thank you.
Thank you, sir. So without wasting much time, we will straight away start with the case discussion. The only thing which I have to announce is we will be taking question and answer at the last of the session. We will be discussing cases first, and then whatever the questions we have, we will take in the end of the session. So I request Rathi sir to please start his presentation.
Good evening, everybody. I hope I am audible to everyone.
Yes, sir.
Yes, sir. Yes, sir.
You are audible, sir.
Okay. Good evening. I am really honored today for conducting this case scenario session for Raigad IAP. I can see the big names here. Mohite sir, Gangulia sir. All these people are there attending this meeting. And it's a long time since I am again on Zoom. Because since last, I think more than 1 year, we are conducting all offline meetings. So coming back to Zoom again, because I could not make coming to Pramod's place. So he had to arrange this on the Zoom. Today we have a very few people here on the meeting. It's a very close meeting. what I have actually done is, Pramod was telling me to talk something on rickettsial diseases. But I thought that with so many times we have spoken on that. So I have selected a few cases in last 2-3 years. Those cases are such that they are very interesting. They are the cases where we had to scratch our head. So actually I had done this presentation in Akola a few months back. Can you see the screen?
Yes, yes.
Yes, sir. Yes.
So there I did it with the name of let us scratch our head, because most of the times our practice, a general pediatrician's practice, say 60-70% is actually on the spinal level, and very few times we have to scratch our heads. So what I did was I went through all my records of cases and could select 4 or 5 cases which I thought would be interesting here to share with everybody. These are not very academic cases, but definitely they made think us more than what we usually think, and something interesting came afterwards. So I think let us begin with the first case. This was a 10-month-old baby who came with history of anasarca since last 20 days. On history, the history was very typical that the child was from upper middle class, was exclusively breastfed till 6 months, proper weaning was done, the child was getting solid food, chicken soup, everything. So just to tell you that nutritional history was perfect. So because most of the time what happens if anasarca comes and we take a nutritional history and we think that it is a malnutrition, then things become very easy for us. From history, it was sure that there was no malnutrition case. So when patient was referred to me, he had few reports with him. So there were 2 reports where you can see that urine albumin was negative. And the doctor who referred it to me did it at 2 different places on 2 different dates to reconfirm that really the urine albumin was not there. Because when anasarca comes, the first thing that comes to our mind is nephrotic syndrome. So that wasn't there. That doctor was so much thinking of nephrotic syndrome that if you can see here, he has even done urine albumin by sulfosalicylic method. I'm not sure I can do it now, but he did it because he thought that laboratory might be reporting it wrong. So let us do it by some other method. So he did it urine albumin, even that was negative. He also did thyroid function test. He thought that let me find out what is the reason for his edema. So he did thyroid function test thinking that it could be hypothyroidism leading to edema. Even that was normal. His eyes were so puffy, that baby's eyes were so puffy that if you can see here, that smart pediatrician even thought of doing MRI brain for looking at the orbit, because the edema around orbit was so prominent that he thought that must be some local cause pushing the eyes forward. So he even thought of doing MRI brain because he was baffled that a case of anasarca with very puffy eyes and he could not find any albumin, the nutritional history was normal. So he thought something might be there locally behind the orbit, and ultimately he referred the patient to me. So when the patient came to me, we reviewed the reports of that baby. We found that urine albumin was not there at all, but serum albumin was gradually falling. If you can see, in 6 days, on 10th it was 3.78. In the 6 days it has fallen to almost 2 grams. So the serum albumin was decreasing. Again in 2 days it becomes 1.92, so it was decreasing. He did serum cholesterol also to see if urine albumin is not positive, you can get hypercholesterolemia as an evidence of nephrotic syndrome. Even that was normal. He did sonography abdomen pelvis, which was again normal. So on 19th of October 2021, I saw this case. I admitted this child as a hypoproteinemia query cause. Urine albumin, if you can see my notes on admission, I'm doing it as a live case. So you can get that feel of how the patient came to me, what happened before he was referred to me. So urine albumin was negative on many occasions. Liver function test, kidney function test, thyroid function test was within normal limits.
Dr.
Yeah.
Rathi sir, Dr. Rathi sir,
Yeah.
can we make it a bit interactive here? It's very interesting. So let people put
I
their
think I have
cases.
many cases, so
Okay.
maybe we
Okay.
may not be able to finish it.
Okay. ठीक है.
So we'll go at some places.
Sure. No problem.
And there was no gastrointestinal symptom. So ultimately, we were thinking that a child of hypoproteinemia with no obvious cause. So we repeated the routine investigation. We found nothing much. There was some anemia. Apart from that, there was nothing much. Urine albumin again done at our place was also negative. So ultimately, we have a 10-month-old child who has no proper diagnosis for his hypoproteinemia. Nephrotic syndrome was obviously ruled out at multiple places and in multiple laboratories. Dietary was out of question because child's weaning, breastfeeding, and everything was perfectly all right. There was no hepatic disease to account for hypoproteinemia because liver function tests were normal. Skin loss hypoproteinemia sometimes is seen in exfoliative dermatitis and burns, but that is pretty obvious clinically, which was not there in this child. So capillary leak syndrome, which causes acute hypoproteinemia, like all cases of dengue leak syndrome or dengue-like diseases, but that was also not there because these are the acute cases and the child was afebrile and platelet count was also normal. There was no raised hematocrit. So capillary leak syndrome was also out. Now what are we left with? So in a child where hypoproteinemia is there, the thing which is left ultimately is a loss of protein from intestine, and that is called a protein losing enteropathy. That is loss of protein from gastrointestinal tract, because this was the only possibility which was left in this child. The gold standard for diagnosis of PLE is stool alpha-1 antitrypsin, but this is available at very few places in India, and obviously it was not available to us. So PLE is usually a clinical diagnosis after you exclude all other causes of hypoproteinemia. Very important thing is diarrhea is not a necessary requirement, because whenever we think of enteropathy, we think that patient should have some GI symptoms. Even I, at the admission itself, wrote in the paper there was no GI symptom. So that was something in my mind, that whether if it is no obvious thing, whether he is losing from GI. But that is not necessary. It can be there, but it is not necessary. One very important clue for clinicians like us who don't have many investigations at hand and we are working at resource poor places is looking at the globulin fraction out of the serum proteins. In PLE, albumin and globulin both are good, because albumin is a lower molecular weight protein, globulin is a higher molecular weight protein, and in enteropathy, you lose both. Now, if you look at a patient of hypoalbuminemia and you want to find out what is the cause, look at the globulins. If it is a liver disease causing hypoalbuminemia, then globulins should be raised. Obviously, we know AG ratio is reverse. If it is a nephrotic syndrome, serum globulin should be normal. If it is PLE, serum globulin should be low. So this is one clinical clue, and in our patient, globulins were always low. In fact, they were decreasing over a period of time. If you can see, globulins had always been low and they were decreasing with advancing time. Now, we could make a diagnosis that it's a protein losing enteropathy, but to tell you the truth, protein losing enteropathy is not a diagnosis in itself. It's a condition, and there are many causes for this, and the causes are multiple. So we started ruling out one by one. The cause, which is cardiac, say CCF or constructive pericarditis, X-ray chest and echo was normal. Cystic fibrosis is one cause, but it is very difficult to do sweat chloride test, and at many places it is not done. So how to screen cystic fibrosis? So we did chlorides and ABG, VBG actually. Hyperchloremic alkalosis is something which can be seen in cystic fibrosis. That was not there. One more screening test which has come up, and we should all be aware of this, is aquagenic wrinkling of skin. If you dip the hand of a child in water,
Hello.
hello, can you hear?
Yes, sir.
Yes, okay.
All apart from Dr. Rathi should mute.
माझ्याला फोन केला पाहिजे होता माझ्याला फोन
All apart from Dr. Rathi should mute themselves, please. Please.
तरी माझ्या डॉरमध्ये आहे पण माधवने सांगितलं की त्यांचं मशीन बदललंय ना आपल्याला काय माहिती नाहीये.
Okay. So another way to screen for cystic fibrosis is very simple. You dip the hand of a child in a warm, the regular water. Normally also, if you keep the hand for 15 minutes, keep one hand in the water, don't keep the other one, so that you have a control also. Normally also, in more than 15 minutes, the skin becomes wrinkled in a hand which is dipped underwater. This test is have been studied intensively, and Dr. S.K. Kabra has also come out with a policy statement that if you find aquagenic wrinkling in less than 3 minutes,
महादेव
it is a very sensitive and very specific test for cystic fibrosis. So that was also being reviewed. There are many other screening tests which people like us can do where sweat chloride is not available.
पण ते
One is even sinus X-ray.
पण ते बोरिंग हात लावू नको म्हणलं तू काय ते तुला
Hello.
तर होस्ट मी सगळ्यांना
पण
म्यूट
ते बदलच काय ते मशीन बदललंय ना काहीतरी.
Dr. Mahajan, please mute yourself. Dr. Mahajan, please mute yourself. Dr.
So there are other screening tests for cystic fibrosis. A simple would be taking an X-ray or CT of sinuses, and many patients, most of the patients of cystic fibrosis would have paranasal sinus opacification. Stools, if they demonstrate excessive fat globules, or IRT, but IRT would be not useful at a 10-month-old child. So various screening tests for cystic fibrosis was done, and it was ruled out at least by screening test. Next cause is the celiac disease. Celiac disease was ruled by TTG, IgA, and total IgA, which was normal. Intestinal lymphangiectasia, but lymphopenia was not there, and in this situation, in PLE, you have a chronic diarrhea, which was not there. So even this was ruled out. Then HIV was ruled out. Then inflammatory bowel diseases were not there because there was no diarrhea. The stool occult blood was negative. The inflammatory markers were normal. There were no extra intestinal manifestations. Connective tissue disorders, ANA was done, which was again negative. So all these causes were also ruled out. Now, when we were thinking as to what could be the reason of PLE in this child, there was some missing link found. As I told you, this child had anemia. If you can see a child with anemia having MCV, which is slightly on the higher side. If you can see the MCV, it was 87, right? Here it was 89. We did it, it was 95. So a child with anemia having MCV, which is higher than normal or on a higher limit, we thought that could it be megaloblastic anemia. So we sent serum B12, and that was quite low. It was less than 100. So we found that child had megaloblastic anemia, B12 deficiency. So we treated the child for B12 deficiency. For 7 days, we gave IV B12. In 7 days, can you see the albumin level, which had dropped down to 1.92, it has become 3.14, and at the end of 7 days, child was edema free. This was without any IV albumin, without any diuretics. So it was a case of PLE secondary to B12 deficiency. I spoke to one or two pediatric gastroenterologists. they said that this is not much reported in the literature, but they have seen occasional case of this and they believe that B12 deficiency can cause protein losing enteropathy. So this was that rare case. I also searched the literature. I just found one case, the child who had protein losing enteropathy due to vitamins B12 deficiency. There the defect was cobalamin C defect. But this is something which is extremely rare, and B12 deficiency is not so rare, but getting a PLE secondary to B12 deficiency because this child had no other cause, because this child responded only to vitamin B12, and after 2 months also we reviewed the child. This is on December and 10 December 2021, after discharge, say 6 to 8 weeks after discharge, and child was still asymptomatic, no edema. So this is the first case where it was protein losing enteropathy, a child who has presented with hypoalbuminemia. Now, if we look at hypoproteinemia, what would be the take-home messages? We have to look beyond nephrotic, kwashiorkor, and hepatic causes, because these three are the commonest causes of hypoproteinemia in practice. But you will have to look beyond them. And there are two organs which can lose proteins. They are skin and intestine. Skin is an obvious organ because if it loses protein, it would have a lot of exfoliation, burns, and you won't miss it. Intestine is something which is silent. You may not have diarrhea, so protein losing enteropathy is something which should be kept in mind in children who have hypoproteinemia. So PLE is a diagnosis. PLE is usually a clinical diagnosis. The only clue, as we discussed, could be getting low globulins in association with low albumin. Once you find PLE, don't stop there. Go ahead, find out what are the causes. You'll have to investigate thoroughly, and you may find some cause, or sometimes you may not find a cause. We found something which was extremely rare. So now coming to the second case. This was a 14-year-old girl presented with very non-specific symptoms, lethargy, anorexia. There was pallor. She had some hyperpigmentation at few places on the face, if you can see. When we evaluated this child on simple investigations, we found that patient had anemia 8.2. Patient had leukopenia, total count was 3,800. PS was showing macroovalocytes. Macrocytosis is one thing, and getting macroovalocytosis makes it more likely to be megaloblastic. MCV was high, it was 95.7, slightly high. So with this, we have a child who has anemia, leukopenia, MCV more, LDH which was 1064, and macroovalocytes on the peripheral smear. Because child was not ready for any further investigation, we thought that let us give a trial of B12 folic acid. So we discharged this child because the child was treated with B12 folic acid, child responded, hemoglobin increased, WBC count increased, and we happily discharged the child. We were very happy that we diagnosed a case of megaloblastic anemia and child responded to it. But 6 months later, the same child came back, again with anemia, again with macrocytosis. This time platelets were on the lower side of normal. Again treated with folic acid and B12, thought we might be lucky this time, but we were not. The child's WBC count went down, platelets came down to 78,000. So now we realize that we are missing something there. Inflammatory markers were completely normal by this time. The repeat urine which was done demonstrated albumin as 3+. So now we had a child, adolescent girl, who had pancytopenia and albuminuria. In just few days time, she developed an ulcer on the palate and a rash on her forearm, on her arm. So now it was very clear that the child of pancytopenia, adolescent girl having albuminuria, rash and palatal ulcer, most likely we are dealing with SLE. So we did ANA by immunofluorescence, which was very strongly positive, 1 in 3,200. And anti-dsDNA was also positive. So it established the diagnosis of SLE. So I realized that when I attended few years back workshop of
एक
Dr.
पानी भर के
Mukhchandani,
गिलास से चम्मच रखते ना नहीं सादा
he told us that connective tissue disorders or rheumatology as such is comparable to a video photography than a still photograph. This is the example where how a child unfolds over a period of time when you are thinking of a connective tissue disorders.
Dr. Pramod, can you mute everybody? Dr. Pramod, please mute everybody. Lot
Yes,
of
sir.
background
Yeah.
noise.
I asked Vishal to mute everybody. Actually,
Tell
Vishal is-
somebody to do it again and again. People are opening for no reason.
Yes,
Lot
sir.
of
Yes.
disturbance. Please.
So rheumatological disorders are like video. You have to see it on a period of time and not a still photograph. Now take home messages here. A very important cause of pancytopenia, we should always remember, is SLE. Now the question here, was it SLE from the very beginning when we saw it 6 months ago, when child was having anemia and very minimal leukopenia? I don't know whether it was that. Had it been SLE that time and we had missed it, it was a really great mistake, because if we diagnosed SLE at that time, we could have prevented or delayed this lupus nephritis, which the child has come to us now, because urine albumin was 3+. Ultimately, she underwent the kidney biopsy and it was lupus nephritis. So this was the second case where possibly we missed SLE for the first time, because patient responded very well for her anemia and leukopenia to B12, and there were good evidences of megaloblastic anemia. But we should have done B12 levels that time, now we realize, or it may not have been, it could be unrelated at all, because there was a period of 6 months intervening. Let us come to a third case. This case I saw in 2019. It was a 16-year-old girl who came to me for short stature. When I reviewed her papers, she had maintained her file from 2010. If you can see, she was a case of nephrotic syndrome and primary hypothyroidism. So she had been treated for last 9 years for multiple relapses of nephrotic syndrome. She was also on thyroid supplements. So she was a case of nephrotic syndrome, hypothyroidism. Her parents were short. If you can see in the notes of previous consultant, there were good enough reasons for her to be short. She was on chronic steroid therapy. She had hypothyroidism. She had short parents. So it was good enough to assume for everybody that her short stature was explainable, and there was no need of going ahead and investigating further. She came to me not for short stature, because she was convinced enough by others that your short stature is explainable. She came to me, if you can see here, because she hasn't achieved the MENAR. At the age of 16 years, she had no MENAR. So, what was the reason? We did the FSH. FSH was high. If you have a high FSH, you can postulate that you have an ovarian failure at the age of 16 years. So we did her karyotype. And if you can look at the karyotype, the girl's karyotype, Naina Thakre, was 46XY. So now it was very clear that we are dealing with a disorder of sexual differentiation, what we previously used to call ambiguous genitalia, 46XY DSD, and it was gonadal dysgenesis. So ultimately the patient was referred to KEM. there it was proved that it was 46XY-DSD gonadal dysgenesis. Her gonads were removed and she was put on estrogen and she was ultimately reared as female. Now you might wonder as to what difference did this diagnosis made her. She was initially also reared as female and now also she is being reared as female even after finding that it is 46XY. Yes, because she was anyway reared as female. It is very important that if your diagnosis is gonadal dysgenesis, you have to remove gonads because there is a very high chance of developing a malignant gonadal tumor. So her gonadectomy was promptly done. She was put on sex hormone. Now she will look more like a female than she would have otherwise looked if we had missed the diagnosis for some more time. Another reason is that when you put these children on estrogen and the proper hormone supplements, their uterus grows. And sometimes in few cases, people have done embryo transplant with donor egg. She won't be able to, of course, produce eggs. And she can have a child in her womb. So this way, there are few things we could do for her by diagnosing her as a case of gonadal dysgenesis. Something interesting is coming up here. 46XY-DSD is a very interesting condition. One type of 46XY-DSD you have already seen, which presented with a short stature, which was gonadal dysgenesis. This is another type of 46XY-DSD. This is called as CAIS. This is complete androgen insensitivity syndrome. This is an extremely interesting condition. These are genetically males, but they are actually super females. They look like female. They look much beautiful female. These females are called as super females. Their height is more than general females. They have less body hair. Their skin is very good. They have very good breast development. But only thing, they can't bear children. So there also you have to do gonadectomy. So it is said that even if you find a female which is very beautiful, has a very good height, has all secondary sexual character, but our professor, who was a very pioneering professor in pediatrics, Professor Sur from Nagpur, told us when we were doing postgraduate in 85, 86, he used to always make fun about this ambiguous genitalia, that even if you like some girl who is very beautiful, you can't be sure she is a girl. And see, he was so true that you have to ask two things to really know that she is a female. One, ask whether she is menstruating properly. That could be one evidence. And second, if she can bear children. Without that, many a times you may find a female who is very beautiful, very good looking, has all secondary sexual character, but genetically she is a male. And this is the CAIS. So take home, short stature female, if you encounter, you have to understand that you have to separate two causes, ovarian failure and all other causes on other hand. So it is very important that you do FSH. A high FSH will tell you that possibly you are dealing with a case of ovarian failure, and there it is a must that you do the karyotype, because karyotype will tell you that possibly you are dealing with a DSD. So this is a next case. We'll come to the last case and then we can have some discussions. This is a 4.5 month old child, a male child, who was a known case of atopic eczema, diagnosed by pediatricians and dermatologists alike. There was a family history of atopy. Patient had severe itching, eczematic dermatitis. When child came to me for the first time in March 2021, the child had severe atopic dermatitis or eczema. There were few pus flakes on the skin. The child also had otitis media that time, but child has no fever, child has no systemic toxicity. So we admitted the child, treated him with the antibiotics and atopic dermatitis. That time, if you can see the report, one thing which was alarming was eosinophil count. That was 44%. There was a high WBC count because we thought there was an infection. There is so much of inflammation and atopic dermatitis, secondary skin bacterial infection, otitis media, and that could explain the high WBC count. Eosinophil count was also high. But in 2 months child after discharge, we thought that it was actually a case of atopic dermatitis with secondary bacterial infection. So we never thought of anything else that time. The child came just in 2 months again with cellulitis of the right thigh. The pus which we sent for microbiology showed it was the Staph aureus. Blood culture again Staph aureus. This time also very high WBC count and same organism Staph. So we thought of immunodeficiency and we started investigating on those lines. Can you see? Is my screen share on?
Yes.
Yes, sir.
Yes, Narendra. Yes.
Okay.
Yes, sir.
So if you
Job
can
chance.
see, the IgE level is very high. If you can see here, IgE level is very high. So this time we treated for cellulitis and we thought it could be hyper IgE syndrome. So we sent the whole exome sequencing. In the meantime, before we could get the report of whole exome sequencing, the child developed abscess on the left dorsum. It was again admitted, drained, treated, and discharged. The whole exome sequencing actually came out that the diagnosis was hyper IgE syndrome. So we could prove that the case which came to us for the first time at 4.5 months old with a properly diagnosed case of atopic dermatitis ultimately turned out to be a hyper IgE syndrome. Child again developed a parotid abscess in December and it was again managed by surgical and medical treatment. Now coming to hyper IgE syndrome, which is also called as Job syndrome, it's a rare primary immunodeficiency. The mutation which we could detect is the commonest mutation in hyper IgE, that is STAT3. These children always have rash in infancy, but it is often missed for atopic dermatitis. They develop abscesses over and above that, boils and abscesses. These abscesses are cold abscesses. This is cold abscess because systemic toxicity is usually absent in such cases. This is a very important feature of hyper IgE, that inflammatory reaction, a systemic toxicity. If you could see in all his presentations to us, first time, he had so much of WBC count, but he had no fever. So toxicity was not there. Second time when he had high abscess, the toxicity was not there. So he was telling us that in spite of having so much of secondary bacterial infection or staph infection, the systemic toxicity was less. So atopic eczema looking like thing with cold abscesses could have made the diagnosis of immunodeficiency hyper IgE. These children also have pneumonia. This child never had pneumonia till now, would have mucocutaneous candidiasis. As far as treatment is concerned, these children need lifelong ceftriaxone prophylaxis. And one thing which has recently in last few years has proved very, very beneficial was a bleach bath. If they take a bath, you add a bleach powder in that their water in their bath water, and these children get less of skin infection. So this is how the child did. So I think we would end here and now could go to some discussion part, right?
Thank you, sir. The first question is asked by Dr. Anjali Madam regarding the first case, that anemia child.
Excuse me, can you see my video?
No, sir.
Narendra, we can't see your.
Yeah.
Now,
Yeah.
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 Yes. Can you hear me now?
Yes, sir. Yes, sir.
Yes, please take.
The first question is for the first case. Dr. Anjali Madam has asked whether the iron studies were done in that patient. Sir.
Which study?
Iron studies, serum iron studies.
No, serum iron. Because child always had necrocytosis.
Yeah.
Right?
First,
it was never
patient, sir.
hypochromic macrocytic. It was always macrocytosis.
Yeah.
The reason why Anjali asked is she recently presented a case of iron deficiency anemia behaving the same way.
Okay, good. Causing protein losing enteropathy.
Protein losing enteropathy.
Yes, that is one of the reason. But we never thought, because there was an anemia. Most of the time we think it is iron deficiency, but this child had proven megaloblastic anemia with macrocytosis, low B12 levels and all. But we did not do iron studies. Yes.
Actually, this level of MCV, we call it like 95 or something. We used to call it as dimorphic rather than macrocytic or macro.
Yeah, but that child also had B12 which was less than 100.
I mean, perhaps that's the reason Anjali asked whether iron was.
Yeah.
Can I comment?
Yeah, please.
Please.
Yeah, Dr. Rathi, excellent cases all across, and it includes immunology and everything. So this first case, we had a similar child, and this child had severe iron deficiency anemia, and only iron helped. And then we read up that there are some cases where, because of iron deficiency, the enzymes which bind the enterocytes are not working well, and then there is a leak of proteins.
Yes.
So that is the explanation. Yeah, yes. But this is the first time I've seen a macrocytic anemia causing such edema.
And the child has promptly responded to only B12. We categorically did not give anything else to this child, not albumin, not Lasix. Because
was iron supplemented?
No, it was not done.
Okay.
We did not give anything else.
Okay.
Only IV Vitcopol C was given, which contains B12 and folic acid. And child very promptly responded to that.
Rathi, could you find out what was the cause and what is the kind of physiological understanding behind it?
I even spoke to Dr. Vibor Borkar.
Yeah.
He said, I had seen 1 or 2 cases, but there is no exact reason. Even the literature, we searched the literature for 1 week, but we could not find any reason why it happens. I don't know.
Anjali, you had given some kind of a cause for iron deficiency causing it.
Yeah. So iron
deficiency.
Enzyme. Yeah. The enzymes which prevent the leak enterocyte binds. There are some binding sites on the enterocytes which are sort of regulated by enzymes which are iron dependent. So that iron deficiency causes the binding to be loose, and the enterocytes lose the protein. But unfortunately, we could not give only iron, because all iron preparation come with B12 and folic acid.
Okay. But their B12 level was normal?
Yeah, so I didn't do B12 levels because we did only iron levels, and the iron levels were very low.
We did not do the iron, you did.
Because the B12 was low.
Yeah. This is how things happen when we are not in the institute, right?
And
we are
Anjali,
always imperfect.
And Anjali, you also did not give the B12 to your patient, am I right?
No, but all. Yeah, but Mahesh, all children with who get iron get B12 and folic acid, because all preparations contain B12 and folic acid.
We gave because we have given IV, so IV we could give only without iron.
And this child didn't have any tremors, so no infantile tremors.
No neurological involvement at all.
Yeah, so that's very unusual.
Yeah, very unusual.
And what was the maternal diet like in this child? Was she vegetarian? Did you confirm?
No. She was giving chicken soup to that child.
Then how would you explain that?
We don't know why B12 deficiency has occurred.
Yeah.
What we are following up that child, if that child again gets B12 deficiency, then possibly we might think of having pernicious anemia.
Yeah, I was just wondering, pernicious anemia is the
right, because a nutritional deficiency is most unlikely in that case.
Right.
Yeah. There is one oral preparation which does contain B12, and that's called tablet Folinex. I don't own any shares in that company, but this Folinex tablet contains lot of B12, about 500 micrograms, and that's a good oral preparation to give. Only tablet.
Okay.
Rathi, what is the relation? Is there any correlation of SLE with B12 deficiency? How does it go? I mean,
No, not
correlation.
at all. Pancytopenia. We have a series of around 52 patients in last 11 years, where pancytopenia was the only presentation of megaloblastic anemia. Only they present. So that's a very well-known cause. So this time also, we initially treated it like that. Patient recovered. Ultimately, to find out that SLE was the cause and not that. I'm not sure whether SLE was there from the beginning.
Narendra.
Yeah.
B12 is the red meat is the big source of B12, not the chicken.
Yes, red meat. Yeah. But they were non-vegetarian. They had a non-vegetarian diet, mixed diet.
No, you mentioned chicken soup especially. That's why.
No, chicken soup, just to tell you that they were non-vegetarian. They used to consume non-veg regularly.
Good, excellent.
Hello, Parvez.
Yes, sir.
You just moderate the session. Take the questions in chat box.
Sir, there are no more questions in the chat box now, sir. We have to ask. Sir, I wanted to ask one question for a cystic fibrosis.
Yeah.
So do we need to do, like you said, that aqua skin test or serum TTG and IgA is sufficient? Because we used to screen our residency only by serum TTG and IgA.
Serum TTG IgA is for celiac. Not for cystic fibrosis.
Yeah, sorry, sir.
Cystic fibrosis screening is very, very difficult.
Yeah.
After IRT, there is nothing very nice thing, but this aquagenic wrinkling is coming up in a very good way. They are selling it is 86% sensitive and specific, and that is fantastic. I mean, just dipping your hand for 3 minutes, one hand, and taking second as control. I mean, whosoever has devised it, hats off to him.
Bedside test.
What a simple thing.
But is it the infant also? Is it effective in the infants also?
Yeah, they have done it across all ages.
Okay.
Yeah, just a comment.
Yeah.
The TTGA would come positive only after 2 years. In an infant, if we have to do it, we have to do a DGP. That is a deaminated glycolated peptide, polypeptide. So DGP is the test that we would do. It's expensive. So just a screening with IgA or TTG IgA would do, I'm sure.
Okay.
That was just a comment.
Right. Thank you.
Sir, regarding the fourth case, hypothyroidism and nephrotic. What made you do karyotype of this girl? I mean,
yes.
What was the reason for that?
The reason was that child did not come to me for short stature.
Okay.
She is a 16-year-old girl, came to me that she hasn't achieved puberty and she hasn't achieved menarche yet. So we did FSH. FSH was high. So it was obviously an ovarian failure. So I thought it might turn out to be something like Turner, maybe.
Okay.
So we did a karyotype and it was 46XY.
Yes.
Excellent.
Yes, and sir, coincidentally, you showed pictures of Rekha and Sushmita Sen.
Are you aware that they are 46XY?
No.
That was the question I was asking to you.
You don't know that?
No, I don't know.
Nobody knows.
Nobody knows.
Oh my God!
How do you know?
Yeah, it is there on the net also, and most of the endocrinologists know. They are patient of many endocrinologists. So they are basically, because they are 46XY.
Okay.
Yeah, so they are complete androgen insensitivity syndrome. So they never had children. You know, both of them adopted the children.
Yes,
they are taking regular female hormones regular.
That's a breaking news for us.
Oh, I see.
Today.
I thought I did not comment on that because I just showed their pictures.
Yes.
Sushmita Sen and Rekha.
Thank you.
If you can read CAIS and celebrities in India or CAIS and film star, you might find out their names.
Okay.
Oh.
माझा हार्ट ब्रेक झाला का तुझा?
Absolute wonderful talk, doctor. I mean, few
Yes.
points which you showed were something revelation. One of the marker of hypoproteinemia approach. It was something wonderful kind of a thing for to teach the PG. Associated globulin you should look at. Globulin is high with hypo, then it's a liver. It's same. It's normal, then it's nephrotic. If it is low, it's GI. I think this is wonderful. This is a new point for me, and I'll definitely take home that particular point from you because investigating enteropathy is extremely difficult.
Extremely difficult. Only one type of, though we call it PLE, it is actually not E. E is a misnomer. It is protein losing from everywhere in the stomach, from stomach to intestine. Enteropathy tells us that it is possibly small intestine. It is not there because the Meniere's disease, which is a hypertrophic gastropathy, is a very important cause of protein loss from the GI. But there, if you do upper GI endoscopy, you will find a very big folds in the gastric mucosa. So that is also one of the reasons. But globulin is a higher molecular weight protein that cannot be filtered from glomeruli. So, but that can be filtered from the, as madam said, that those enterocytes, when they are separated, the protein leaks from there. So even high molecular weight protein will go away. So that's why the globulin decreases.
And another takeaway point from your talk is that any adolescent girl who has any kind of skin rash and pancytopenia like picture or even bicytopenia, think of doing ANA. It's not very expensive.
Yes,
Absolutely.
ANA must be done in adolescent girl with pancytopenia. Even 2 lines, not necessary all 3 lines. Even if 2 lines are less, you must.
Yeah. Excellent.
In fact, a similar kind of this enteropathy patient we had, if you could permit me just 3-5 minutes. This was a case from Vidarbha only. Government class 1 officer shifted, relocated to our area and was being treated right from the infantile age group as an eczema, was labeled as eczema. But by 3rd year, he developed well till 2 years and then started losing milestones. And from 3.5 years, he was just stopped walking. So he was brought to me at 4.5 years of age. Idiopathic child, eczema, stopped walking, extremely irritable, and then investigated for multiple things and found to be having scurvy, rickets, edema because of hyperproteinemia, and then investigated further, turned out to be enteropathy, and then with the scopy, he had got eosinophilic enteritis, and it was a combination of eczema with eosinophilic enteritis. So he responded very well to steroid and literally started walking within next 1 month after vitamin Z and vitamin D and all the supplementation, and it's now doing very well. So I think this particular aspect of hypoproteinemia called enteropathies, I believe even is quite neglected or kind of missed in the pediatric fraternity also. So your case was absolutely wonderful. I think Anjali, this is continuation of your case of iron deficiency is B12. So some wonderful 2-3 take home from this clinic.
So PLE can be a Pandora's box.
Yeah, yes. Absolutely.
And PLE is not a diagnosis.
It's not a diagnosis.
Yeah, and not to forget another important thing. All of us or many of us keep giving the excuse that I don't have facility for investigation. Look at Dr. Rathi sir at Akola. Yes. Always when you think that, always think of Dr. Rathi sir. And we have no reason to give excuses. We are so close to Mumbai. We can do everything.
Nowadays, everything can be done in any place.
Everywhere, absolutely.
Right. We are doing whole exome sequencing and finding out so many rare diseases. Few cases reported.
Absolutely.
So you can do everything. You can do even whole exome sequencing. So there's no point.
Super.
There are few investigations where we are really, one is serum parathyroid and another is serum insulin, because they have to be done on the fresh sample. That's 2 things we are always I mean, we find ourselves disabled for that. Because even if we send sample to Mumbai, it takes 12 hours. And the labs don't accept that because those two samples are to be processed on a very fresh blood. So these are the two things we are still fighting for. Otherwise, we can do anything.
Absolutely. We do see a lot of insulin hyperinsulinemias, and we do see a lot of hypoparathyroidisms, especially those who are dealing with neonatal practice. We have these two are not very, I mean, they are quite reasonably common, I would say. Not very common, but yes, we do see quite often. That's true. Wonderful. Absolutely. Pramod, thank you very much for getting Dr. Rathi here. I mean, amazing clinic. And
he was behind me from last 6 months.
So next month we'll have Girish Subramanian also.
Oh, absolutely. Girish should come. He is another difficult man to catch. Dr. Rathi is also very difficult man to catch.
No, sir.
No, I have tried you on DIP, if you recall.
Yeah, DIP that time, yes.
I know some of the other reason came up and I could not get
yes,
you. Yes. You are always there in our hit list, you may say.
Definitely.
Amazing. Thank you very much.
Dhananjay. Hello. Hello, Dhananjay.
Yes.
Parvez, please conclude.
Hello, sir.
Yeah.
Please conclude. Because
sir. Narendra is having some sound problem at his place, so he told me to give the Thanksgiving. At the outset, I am really thankful to have such.
Just a minute. Narendra, Dr. Vikas More is our Vice President, IIP Raigad.
Oh, I see. Hello, sir.
Hello, good evening, sir. So actually, sir, I was so eager to see you because Vankade sir is talking about it since last 1 month. That and he had such. Actually, I was with him in Goa, and we were talking about you only. Like Rathi sir is like that. He is such a brilliant person, and he has got so many gold medals. So I was so much curious to see you at least. And this is your excellent presentation. It was really insightful.
Narendra, मेरे को अकोला आया तो चाय पिला देना.
I'll come to Khopoli now.
You are welcome.
Okay. On the behalf of IIP Raigad, I'm really thankful to Rathi sir for giving such a beautiful presentation and very unique cases. And they gave us the take-home messages. And I'm really thankful to Anjali Gokar madam. She added a very point and made the discussion very lucid. As always, Mohite sir is participated in this presentation and added his wisdom. Also, our dear President Dr. Pramod Wankhede sir, due to his initiative, we got Rathi sir. Really, thank you so much, sir. And Dr. Parvez, who moderated this session, I'm really thankful, Dr. Parvez, and also all the delegates who have attended this Zoom meeting, and they appreciated our efforts to disseminate the knowledge. So thank you so much for this excellent session, and I declare that we are ending this session. Thank you so much.
Thank you.
Thank you, Narendra.
Thank you very much. Thank you, everybody.
Thank you,
Thank you,
sir.
Dr. Rathi.
Thank you for inviting me. Thank you.
Thank you very much.
Thank you.